Hi everyone, I hope you're doing well. Today I'll be reporting a case of pulmonary embolism from mass effect compression in a PERC negative patient with suspected uterine leiomyoma or fibroids. So we're familiar with Virchow's classic risk triad for developing deep vein thrombosis and pulmonary embolism, and it includes the presence of venous stasis, hypercoagulability, and endothelial damage. These factors have been distilled into diagnostic tools like the pulmonary embolism rule-out criteria, or PERC, and the Wells criteria for both pulmonary embolism and deep vein thrombosis, which consider top risk modifiers like active cancer, immobilization, recent surgery, age, and estrogen use, along with common clinical presentations like hemoptysis, tachycardia. However, these criteria may not always account for the rare but significant predisposition to venous stasis caused by mass effect compression of femoral or sometimes iliac veins by benign pelvic lesions such as uterine leiomyoma or fibroids. Along with exerting direct pressure on deep veins, heavy uterine bleeding from fibroids can also lead to reactive thrombocytosis, contributing to a hypercoagulable state. Fibroids are the most common benign tumor in female patients between ages 30 and 50, diagnosed in up to 70% of Caucasian women with or people with uteruses, and upwards of 80% of Black or African American people with uteruses. Yet they remain an under-recognized and serious cause of thrombosis and embolism in people born female. This case report details a 47-year-old woman who presented with atypical signs of pulmonary embolism, lacked textbook prothrombotic etiologies, and communicated an unclear medical history, which led to diagnostic challenges and demonstrated the importance of considering uterine leiomyoma in the evaluation of embolic events in people assigned female at birth who are premenopausal. So the patient was a 47-year-old African American female who came to the emergency room because she was concerned about sharp right flank pain, right upper quadrant pain, and right upper back pain for 3 days, which was initially intermittent and controlled with ibuprofen and progressed to constant and unalleviated by over-the-counter pain medication. It was pleuritic chest pain, worse on deep inspiration, and lying supine, not associated with eating or any specific foods. She reported difficulty breathing deeply due to pain, but she didn't feel short of breath. But her symptoms were accompanied by anorexia and occasional chills. However, she reported no fever, cough, hemoptysis, wheezing, pre-syncope or syncope, nausea, vomiting, diarrhea, constipation, dysuria, gross hematuria, or leg pain or lower extremity edema. So our differential diagnosis was pulmonary embolism, pericarditis or pericardial effusion or tamponade, atypical pneumonia, pneumothorax, acute coronary syndrome, abdominal aortic dissection, biliary colic, cholecystitis, nephrolithiasis, pyelonephritis, rib fracture, and muscle spasm. So because of the kind of variable locations of her pain and the vagueness of the rest of her symptoms, our differential was pretty broad. Her medical history was relatively non-contributory. It included well-controlled blood pressure, and then she reported a history of uterine cysts accompanied by menorrhagia and infertility, but otherwise healthy. No recent trauma, surgery, immobilization, active or recent cancer, or long plane or car rides. No family or personal history of blood clots or hypercoagulation disorders. She was a non-smoker, no recreational drug use, very occasional alcohol use, and no recent illnesses. She uses a progestin-only implant for menstruation regulation, like a Nexplanon, and had no history of abdominal surgeries. On exam, she was well-nourished and well-developed, afebrile, non-diaphoretic female. She was sitting in a guarded, hunched posture and speaking in short sentences on room air with frequent breaks to inhale. So I thought she was pretty objectively short of breath, but she felt like it was just because she couldn't take a full breath. Non-toxic appearing, pleasant, and cooperative. Her HENT exam was normal. Her neck was normal, no lymphadenopathy, no JVD. Her chest exam, mild tachycardia, regular rhythm, no friction rubs, muffling or murmurs or extra sounds. Her capillary refill, going to peripheral vascular. Her capillary refill was less than 2 seconds. Her brachial and popliteal pulses were 2+, and she had no peripheral edema. Her respiratory excursion was limited due to pain, but she had vesicular sounds throughout without crackles, rales, bronchi, or wheezing. Her abdomen was soft and non-distended with normal bowel sounds, but she was very tender to palpation to the right upper quadrant. She also I would say had a positive Murphy sign. She arrested her breath on Murphy's, but it was due to back pain that she couldn't tolerate, so she stopped breathing. So um, a little bit of a different positive Murphy sign, but and she had no rebound tenderness, no CVAT, and no pulsatile mass. And then her lower extremities were identical circumference at the ankle, calf, and thigh bilaterally. No warmth, redness, tenderness to the deep venous tracts, and Homan sign was negative. Oh, and her vitals, which I meant to do first, were all in a normal range, but approaching suspicious. So her heart rate was 99, not quite the 100, and her O2 sat was 96, not quite the 95%, which will become important later. Sorry about my dog. All right, so initial laboratory testing, UA was negative for blood or any signs of UTI, and her urine HCG was negative. CMP was within normal limits. Her CBC showed mildly elevated leukocytes at 12,500. But if you've done your emergency room rotation, you know that we don't even blink at that white count. Her platelets, though, were notably elevated at 520,000, and she had microcytic anemia, pretty mild, with hemoglobin of 11.1 and MCV of 77, which was likely due to her heavy periods. Her BNP was 120, mildly elevated, non-specific, but her troponins were normal. Her EKG and chest imaging, oh goodness, I'm getting distracted by my dog. So her chest x-ray was normal. Her EKG had T-wave inversions in lead 3, but was otherwise unremarkable. So the challenges that we encountered is that the patient's history was a little unclear. She reported uterine cysts instead of what we realized in retrospect was more likely a previous diagnosis of uterine fibroids. Had this information been available, it may have been pertinent to a supervising clinician who recognized this as a risk factor, even though it's not generally incorporated into the classic risk factor and criterias. Her signs and symptoms all approached a presentation consistent with pulmonary embolism, but stopped short of the qualifying criteria or convincing history. So this patient technically perked out. She's less than 50, does not use estrogen, no hemoptysis, no history of DVT or PE. Her heart rate was just lower than 100. Her O2 sat was just above 95%, and she had no recent surgery or trauma or signs of DVT, no unilateral leg swelling. Her Wells criteria was also either a 0 or a 3, depending on if you thought that PE was #1 diagnosis or equally likely. But either way, the algorithm would direct a score of less than 4 to perk the patient out, and she would have perked out. So it really came down to the clinical gestalt as the only qualifying factor to pursue further diagnostics of pulmonary embolism, which necessitated a defense to the supervising PA and the attending physician based on the evaluation that I had performed. I still thought that the pretest probability of pulmonary embolism was high enough to warrant continuing a PE workup. So once we decided that we should continue with that, since we were in the emergency department, we decided to skip the D-dimer even with the PERC and Wells scores and proceed directly to CTA and other imaging, since we felt like we had sufficient pretest probability based on that shared discussion. So when we performed the imaging, we were doing the CT of the abdomen and pelvis with and without contrast to look into other things on our differential. And it didn't show any kidney or ureter stones, didn't show any gallbladder disease, but what it did show were large uterine lesions, apparently exerting mass compression effect on nearby structures, which was causing a non-occlusive DVT in the left common femoral vein and mild hydronephrosis. And then the CT pulmonary angiography showed a non-occlusive segmental pulmonary embolism in the right lower lobe. So our diagnostic reasoning, other than that we had found kind of the suspected diagnosis on CT and CTA, we were able to rule out, atypical pneumonia, pneumothorax, aortic dissection, rib fracture, basically from the chest X-ray. The pericarditis and tamponade, there was no diffuse ST elevation for pericarditis on the EKG or electrical alternans for tamponade. Also, the physical exam, there was no friction rub or muffled heart sounds, and she had no JVD, so those were pretty unlikely. For acute coronary syndrome, the EKG was unsupportive. She didn't have risk factors, even though this whole presentation is about how, even though there are no apparent risk factors, there may be pathology. And her chest pain was non-exertional. It just wasn't very consistent with ACS. And then the CT pretty much ruled out biliary colic, cholecystitis, nephrolithiasis. Her presentation wasn't very consistent with pyelonephritis, and it wasn't supported by the urinalysis. She was afebrile. She had no costovertebral ankle tenderness. And then muscle spasm was really a diagnosis of exclusion, and clearly another diagnosis was more likely. So the therapeutic interventions, she was admitted to the hospital ICU in a guarded but stable condition for anticoagulation. Anticoagulation actually started in the ER. She was started on IV unfractionated heparin, a bolus of 80 units per kilogram. And then after she was admitted, it was followed by 18 units per kilogram per hour for a maintenance dose for 2 days, trying to keep her within an APTT range between 60 and 80 seconds. She was also given some Norco for pain. She was to continue anticoagulation outpatient with Eliquis 5 milligrams twice daily for 3 months. She was also given a gynecology consult. They suspected leiomyoma, but couldn't rule out leiomyosarcoma, especially in the setting of a hypercoagulable state. They did do a pelvic ultrasound when she was in the hospital, and they found a 15-centimeter massively enlarged uterus with a 9-centimeter left-sided mass that was pushing on the femoral vein. They recommended an endometrial biopsy to rule out endometrial hyperplasia and carcinoma. And then if it was confirmed to be benign leiomyoma, then to do a hysterectomy or refer to gyn-onc if it ended up the unlikely event that it was a carcinoma. In the meantime, while she was in the hospital, an inferior vena cava filter was placed until the hysterectomy could be performed, due to the high likelihood of recurrence despite outpatient anticoagulation. So her hospital course was completed after inpatient anticoagulation, and then she was discharged 3 days after admission with a prescription for outpatient anticoagulation. She experienced resolution of pain and resolution of difficulty breathing with deep inspiration. Her white count and her BNP normalized, and the patient was referred to outpatient gynecology for biopsy and hysterectomy. She was very motivated to pursue this plan and prevent future embolic incidents, and she expressed gratitude and relief for the diagnosis, the initial treatment, and the referral to definitive cure at the occurrence of a minor PE before a massive or occlusive event could have happened. So this was, all in all, a pretty minor PE, and it was non-occlusive of her femoral, the DVT was non-occlusive of her femoral vein, likely because it had already embolized, which made it a little challenging because she didn't have leg swelling because it wasn't occlusive. But then also the embolism was small enough that it didn't cause too much of a problem other than the very significant pain. She was also to follow up with primary care to track her complete resolution of symptoms with a low threshold for repeat imaging as needed, as well as either repeat imaging or going back to the ED. She was given strict return precautions for either signs of recurrent PE or bleeding because we were anticoagulating her, and she has a history of heavy periods, and that may exacerbate that even further. So we gave her very strict precautions to come back to the ED with any signs of either bleeding or recurrent PE. And then the outpatient follow-up notes were unavailable to me while I was in the ED, and my rotation ended without additional patient contact. So I don't know her full story, but hopefully she was confirmed with benign lesions and got the hysterectomy. So some strengths in managing this case was the available of immediate and comprehensive imaging in the emergency department, which allowed for a really thorough and quick workup of a wide multi-system differential. In the absence of compelling evidence to investigate PE, the ability to quickly perform both the abdominal pelvic CT and the CT angiography revealed both the primary diagnosis and the underlying pathology. If the patient hadn't come to the emergency room, a primary or urgent care workup may not have warranted immediate imaging and treatment due to her low PERC and Wells scores. The anticoagulation was able to begin immediately and prior to hospital admission, reducing damage to the lungs and heart. And her hospital course also connected the patient to specialist consults for continued evaluation of uterine masses and curative opportunities. However, some weaknesses in this patient's management. Her previous medical history was not available to confirm the probable past diagnosis of fibroids, and the details that supported fibroids over uterine cysts were not adequately considered. That is, a history of heavy menstrual bleeding and infertility. When I was taking the history, it was insufficient to differentiate between the two when at first her gynecological history appeared to have limited pertinence. While the femoral DVT and segmental PE were non-occlusive, the left popliteal pulse may have been weakened and vesicular sounds in the right lower lobe may have been decreased, but I didn't perceive either of those signs. So in retrospect, I think maybe a more thorough, more sensitive physical exam may have warranted a few more abnormal signs than I picked up. And then being mild, the hydronephrosis of the left kidney was taken as a sign of the mass effect of the uterine lesions and not treated as a separate diagnosis with additional specialist evaluation and treatment. So if the effect was to continue until the workup and the hysterectomy were complete, then the patient may have benefited from a nephrology consult just to monitor the progress and prevent any renal damage. So the key takeaways that I found were when a premenopausal female patient with pleuritic chest pain presents with borderline signs and symptoms and no classic risk factors of pulmonary embolism, consider mass effect compression on femoral or iliac veins from uterine leiomyoma as an underlying pathology and significant etiology for DVT and PE. In the absence of a known history of fibroids, include direct, specific questioning about gynecological history, like prolonged or heavy menstrual periods, clots, and infertility, in order to assess the possibility of a fibroid diagnosis and underlying cause of their pleuritic chest pain. If not already performing a pelvic imaging for other diagnostic purposes, like we were with the CT abdo-pelvis, consider a pelvic ultrasound in addition to the CT pulmonary angiography when evaluating a patient suspected of having a pulmonary embolism, but who doesn't have obvious risk factors, because then you may be able to diagnose not just the pulmonary embolism, but the cause and help prevent recurrence that way. And then just always remember that the diagnostic criteria that we use, like PERC and Wells, are useful, but they have obvious limitations. So always trusting your clinical intuition when an atypical presentation feels suspicious. That should be the ultimate deciding criterion in the pursuit of a challenging diagnosis. These are the sources I used for today's presentation. Thank you for your time, and I hope you have a wonderful rest of your day. Okay, take care.